Al-Alawi. I am a bariatric surgeon and I mainly deal with metabolic surgery. So majority of my work is metabolic bariatric surgery. So I hope that we can give you an overview tonight and we'll give you some information that will be valuable. There is something about my specialty is that we go by the WHO definition of health. So if you come and ask me, what is the definition of health? By the WHO at the end of the 1970s, beginning of 1980s, they have given a definition for this word, which is the psychological and then the physical well-being of an individual. So I consider myself in my specialty that I provide people with health. My specialty might not be life-saving on an immediate term, but it's actually life improvement, and this is what I provide my patients with, which is health. So this is what I'm going to talk to you about the bariatric surgery assessment, optimization, and how to proceed with the procedures. So let's go through the slides. Next slide. The learning objectives here. I know some of you are surgeons, dietitians, physicians. You're all very welcome. This is important for everyone. So the learning objectives here is for you to recognize that there are many procedures available. Bariatric surgery, if I tell you the number of procedures, I'll probably exceed 40 to 45 procedures for weight loss and for treating metabolic syndrome. I need you to understand that patient assessment is very, very important before you choose your procedure. You need to assess the patient and choose the appropriate procedure for the patient. Different procedures are suitable for different patients. The importance of preoperative optimization. I'm going to talk to you about protein, amino acid optimization, vitamin supplements, and the way to optimize your patient according to their assessment. So we're going to understand that together, hopefully, this evening. And I need you to understand the importance of proteins and amino acids. So let's go through the slides together. Let's talk about the assessment. When you're assessing a patient, someone comes to you to the clinic saying that we need to lose weight. So the first thing you need to do is you need to understand whether is this a purely bariatric patient or is this patient purely metabolic or they're bariatric metabolic patients. And more than 90% of our patients are actually bariatric metabolic. So you need to do the general profile, which includes the laboratory and radiology. You need to do the metabolic and hormonal profile. And I'll just give you some examples like insulin, cortisol levels in the morning and in the evening, TSH, HbA1c. These are just examples of the metabolic and hormonal profile assessment. We could do more according to the patient's needs and according to the case. The gastrointestinal profile, like endoscopy and barium meal, is very important to assess which procedure is suitable for which patient. And I'm going to tell you and give you some examples here. The general profile, we usually request laboratory and radiology. So the idea is to replace any deficiencies. So if there are any deficiencies like iron deficiency, vitamin D deficiency, B12 deficiency, you've got to replace it. But most importantly is that we're diagnosing other diseases just by assessing our bariatric patients. For example, iron deficiency in a male patient. That is something that should ring a bell. Iron deficiency in a male patient could reflect polyps, could reflect blood disorders, or most importantly is colonic malignancies. And at the moment, if we have almost in the year of 2019, we've diagnosed 12 male patients with different gastrointestinal malignancies, incidentally coming to our clinic requesting assessment for bariatric surgery. Incidental gallstones, renal stones, sometimes you diagnose problems with parathyroid glands, parathyroid adenomas. We've diagnosed a couple of cases over the past 5 years, incidentally, just by assessing our patients. In female patients, polycystic ovaries. Let me go back to the slides. Kim, can you see the slides? Are we okay?
Yes, Professor Ines.
Okay, sorry, because on my screen it was gone. So if we can go back to our previous slide. Again, polycystic ovaries, uterine fibroids could be diagnosed in female patients, again, incidentally. So you need to refer your patients to appropriate specialties to get clearance to continue your bariatric planning. Metabolic and hormonal profile. Every patient of ours gets assessed for insulin resistance. And as you know, with female patients diagnosed with polycystic ovaries could actually have insulin resistance. And it's very highly, the incidence is very high, and the relationship between polycystic ovaries and insulin resistance is also very close. Fatty liver, if we find fatty liver, we request fibroscans to assess the degree and the need of treatment. Thyroid function test, cortisol metabolism morning and evening, and we try to control metabolic syndrome. And we then make a decision whether we need to control the metabolic syndrome before the bariatric surgery, or actually bariatric surgery is going to treat and control the metabolic syndrome. You need to assess your patient right. Let's look at the gastrointestinal profile. Many of my colleagues would do endoscopy. Endoscopy is one of the main investigations that people ask for in a bariatric clinic, and usually they're assessing for acid reflux, H. pylori, ulcers, polyps. But very importantly for me personally, I like to do the barium meal. I do the barium meal test, a radiology test, where you swallow a contrast and you assess how long does it take between swallowing the contrast and the contrast reaching the small bowel loops, and that reflects the gastric emptying. Let me show you an example, and let me tell you why this test is very important. Look at this barium meal here. Can you see this as an X-ray? If you look carefully, you'll see here that the stomach is emptying when the patient is swallowing the contrast, and the contrast reaching the small bowel. You can see the time given here. So when the patient swallowed the contrast, it was 3 o'clock and 10 minutes. Did you see that? Kim, was that clear?
Yes, Dr. Ines.
Okay, and now the patient had swallowed the contrast had passed through the stomach into the small bowel. Look at this, we're already into the jejunal loop here. We already started absorption at 3 o'clock and 11 minutes. It took 1 minute for gastric emptying. Let's look again. 3 o'clock and 10 minutes when the patient swallowed the contrast, and it was 3 o'clock, 11 minutes when the contrast had already reached the small bowel and started absorption. So this is simulation of eating. Do you think a sleeve gastrectomy would help this patient? Look at the volume. The volume they swallowed is probably half a glass full of contrast, and they've already filled the stomach with contrast. Look at that. Half a glass full of contrast had already filled the stomach, and we're already emptying the stomach. So the problem is not with volume here. If you do a sleeve gastrectomy, a restrictive procedure on this patient, are they going to lose weight? Or is sugars and sugary drinks and high-calorie drinks gonna pass very comfortably through that stomach? So gastric emptying time is a very important factor to choose your procedure. People with low glycemic index, which means they get hypoglycemic attacks with a lower index, which means that the normal blood sugar for them ranges between 100 and 150. And you know, for most people, that is considered as having a high fasting blood sugar, for example. But for some people with a low glycemic index, the normal blood sugar for them would be 150, 160, 170. So when you do a gastric bypass on these people, they're more likely to develop dumping syndrome and hypoglycemic attacks after the surgery. So all these metabolic, hormonal, gastrointestinal, and general profile. All these assessments is important for you to assess which surgery for which patient. So again, the choice of procedure according to the assessment. As I said, restrictive procedures like the bioenteric balloon, the laparoscopic sleeve gastrectomy, the gastroplasty, they might be contraindicated with patients who have a high gastric emptying or who have got severe acid reflux. So you might want to consider treating the acid reflux or change your procedure to a bypass procedure or to a low pressure system procedure if you want to do a weight control study. Sorry, my screen here keeps on leaving the chat. So are you still there, Kim? Can you see me? Something wrong with my screen, I think. Can you see my slide, Kim? Can you see the slide?
Yes, Dr. Ines.
All right, so let's go back now. Restrictive procedures are contraindicated for people with a high acid reflux. You know why? People with big stomachs who have a hiatal hernia or a lax esophageal sphincter and they're having reflux, but it's asymptomatic because the stomach is big and the acid is diluting. When you come and do a restrictive procedure on these patients, you make the stomach smaller, so the reflux then is symptomatic. So before bariatric surgery, there is reflux, but the reflux is asymptomatic. After a sleeve gastrectomy or a balloon or a gastroplasty, the reflux would become symptomatic and very annoying, and people would develop esophageal ulcers and problems. So please assess your patient before you choose the procedure. I will show you some example of scans and x-rays in a moment. So in terms of malabsorptive procedures like the gastric bypasses, any type of gastric bypass, be it the Roux-en-Y, the mini gastric bypass, biliopancreatic bypass, duodenal switch, all the bypass procedures might be contraindicated with severe mineral deficiencies. People with severe iron deficiency, severe B12 and folate deficiency, you might consider your options whether you would do a bypass procedure on them. So please assess your patient well, assess the risk benefit and the no benefit ratio for every procedure that might be suitable for your patient. If your patient, you think that they're suitable for a sleeve gastrectomy, then go back to your assessment and assess the risks, be it short-term or long-term. Assess the benefit in terms of weight loss and the control of metabolic syndrome, and assess the no benefit. Remember the x-ray I showed you a minute ago where the barium meal is passing very quickly through the stomach. If you do a sleeve gastrectomy on these patients, they're not going to lose weight. You might not harm them, you might not give them a complication, but they will not get benefit. So this is what we call a no benefit ratio. This is a CT scan. Now I appreciate you're not radiologists, some of you are not surgeons, you might have not seen an x-ray like this, but look at it. This is a CT scan. It's showing you a patient who had a sleeve gastrectomy in the past and coming with weight regain. Can you see here, Kim, can you see my cursor?
Yes, Dr. Ines.
You can see my cursor. Okay. Look at the ribs and look at the skin. Okay. Look at the hip and look at the skin. So this patient is obese. This patient BMI is 47. This patient is obese with a BMI of 47 after a previous sleeve gastrectomy. Now they have regained the weight and they've come to the clinic requesting redo bariatric surgery. When we did the CT scan, look at what you see. Can you see this white line here? Can you see this white line? This white line is above the diaphragm and it's going into the thoracic cavity where you can see the lungs. Can you see everything? Black here is air and the black here is lungs. This is the heart. This is the diaphragmatic muscle. This is the diaphragm. And here, this is the liver. You're not supposed to see a staple line, a gastric staple line up in the chest. This patient had a previous sleeve gastrectomy with half of the stomach is up in the chest, up in the thoracic cavity. This patient had suffered severe reflux after the sleeve gastrectomy, and the only thing that gave them relief to their symptoms is actually eating carbohydrates and sugars. So what happened after the sleeve gastrectomy? They did not lose weight. In fact, they gained weight. So again, I would like to show you this. If you see my cursor here, you can see I'm showing you the staple line of the previous sleeve gastrectomy, although the stomach is not big, but half of the stomach is above the diaphragm and the other half of the stomach is below the diaphragm. So patient assessment is very, very important. Okay, again, if we go to the next slide, let's see if this happens. Okay. So we'll leave the questions for the end. I've just spoken to you and given you examples about the assessment. Let's go and talk about optimization. Now you've done your patient assessment. You've decided that, for example, a procedure, whatever it is suitable for your patient, be it a sleeve, a gastric bypass, a biliopancreatic bypass, mini gastric bypass, whatever the procedure is that you've decided for your patient. Now you had made plans that your patient is going to achieve a few goals. So when you're doing your planning, you need to optimize your patient preoperatively. You know, after bariatric surgery, there's going to be flabbing, there's going to be hair loss, they might get depressed, there might be depression, there might be anxiety. All these things might happen. So you need to consider optimizing your patient before going ahead with the surgery. So in the period of optimization, and this is well before you go to the operating room and operate on your patient, we usually take between 6 to 12 weeks optimizing our patients. So if there are any deficiencies, we replace them. Iron deficiency, B12, zinc, magnesium, whatever it is, whatever the deficiency is, we replace it before the surgery. Our internal medicine colleagues help us a lot in doing this. So vitamin replacement or mineral deficiencies replacement is done by the internal physicians. They help us very closely in deciding how to go on with the doses and to reassess before going ahead with the surgery. In terms of preemptive physiotherapy, many of our patients would come to us with spinal problems, be it disc disease, cervical disc, lumbar disc disease, lumbar disc prolapse, or they could just come to you with scoliosis, kyphosis, or kyphoscoliosis, where you've got the spine is bent into an angle. So what happens here is that these people who have spinal problems have developed a center of gravity that is suiting their body according to their weight. So our physiotherapy department, our physiotherapists help us to assess the center of gravity for our patients. So they're standing straight, but the spine is going into an angle. And this is how they develop a center of gravity. So some muscles might be stronger than other muscles. And if you don't pay attention to these details, you might end up doing a sleeve gastrectomy on your patient, losing them a lot of weight, losing them a lot of muscle, skeletal muscle volume, and therefore you develop more weakness to the spine, and you give them back pain and symptoms. Maybe before the surgery, they did not have symptoms, and after surgery, they developed spinal symptoms. Those who have spinal diseases and their orthopedic surgeons are telling them they're not going to operate on them until they go and lose weight, and they come to you to lose weight and they get worse and more severe symptoms than they were before surgery. So you need to pay attention to center of gravity and ask your physiotherapist to give your patient preemptive physiotherapy sessions to strengthen these muscles. You need to know what weight are you losing your patient. How much muscle mass will they be losing? How much fat mass will they be losing? You need to assess that before the surgery. It's not random. This is not by chance alone. The third point here is the proteins and essential amino acid supplements. We give all our patients these supplements prior to surgery to maintain muscle mass. Now, this is not evidence-based. This is observational to our department. When we give our patients proteins and essential amino acids 3 months before the surgery, between 1 to 3 months before the surgery, we've observed that they have a better outcome. Now, we're doing this study as an observation to our work, comparing people who didn't get this optimization to patients who got the optimization, and we're assessing the outcome. So we're doing a 5-yearly follow-up at the moment. We're following up these patients for 5 years post-operatively to be able to see the benefit of the optimization that we're doing. Now, many of your male patients would report back to you after losing weight, after losing more than 70–80% of their excess weight. They might come and report to you sexual dysfunction, for example. So in our department, again, this is an observational study where we've started giving our male patients omega fatty acids and different multivitamins to maintain the sexual functions post-operatively and post-losing weight. And we usually look at between 50 to 80% excess weight loss, and then we look at the differences, and compare patients who received the optimization to patients who did not receive the optimization. At the moment, after almost 3 years of follow-up, we are seeing much better outcome with those who had received optimization. We're waiting to finish our observational study for 5 years, and hopefully we will publish some data. In terms of plastic and cosmetic surgery assessment, why leave it until later? Why leave it until they lose 50 or 60 or 70 kilos, and you know they're going to develop an apron, you know they're going to flab, you know the breast is going to flab, you know the abdomen is going to flab. So why leave it until later? Now, it depends on how cooperative your plastic surgical colleagues are with you. Many plastic surgeons will tell you, we're not going to operate on patients with a BMI of above 30, but we're not going to operate on patients with BMI below 22. So they don't help you when the patient is obese, and they don't help you either when the patient had lost a lot of weight. So many plastic surgeons would want to work on a perfect model to achieve the perfect look. The problem is with bariatric surgery, this doesn't work. We need to support our patients. So what we do is we get our patients to be assessed by the plastic surgeon before we make the plan for bariatric surgery. So we make a plan with the cosmetic surgeon that we will refer our patients back to the cosmetic surgeon when they are in the ideal BMI for cosmetic procedures. Now, I know my patient is probably going to achieve or going to get to a BMI of 22, 23, and I know that's not liked by the plastic surgeon, but I will catch my patient when he's at a BMI of 27, 28, and then I'm going to refer back to the plastic surgeon so they can assess whether we need to do a full body contouring or we need to do a breast lift or an abdominoplasty. This way, you give your patient that psychological well-being that we discussed in the beginning of our talk. So yes, give your patient metabolic treatment, treat their metabolic syndrome, treat their diabetes and hyperlipidemia and what have you, but you need to also consider their cosmetic outcome, because that will reflect on their psychological outcome and their self-esteem and their self-love to themselves. So we always tell our patients, love yourself. Now, if you tell your patient to love yourself, love themselves, and when they have an apron hanging to their knees and they've got the breasts are flabbing, they've got their faces flabbing, it's not realistic. So we try to get plastic surgical or cosmetic surgery assessment and cosmetic surgery help well before we do our bariatric surgery. Now, very important topic, and the literature has no guidelines. What do you do, and what do you give your patients preoperatively, and how do you pre-optimize them with amino acids? Let me give you a general idea. You know full well that bariatric surgery is associated with loss of lean body mass. So muscle mass is lost after bariatric surgery for many reasons. Food intolerance, they're not able to eat, they're not tolerating food, they're not tolerating the bulk of proteins like the meats and the steaks and the chicken, they might not tolerate it. They've got reduced intake. If you do a tight sleeve gastrectomy on a patient, they might not be able to take in enough. They go into a hypercatabolic state and they start metabolizing their muscles. So what we do here is we do a preoperative assessment of the lean body mass. This is done in a few different ways. The easiest way, the most cost-effective way, and accurate enough way is the body composition analysis, which is done by the electric bioimpedance. Many of us will have this in our clinics, and we look at the body composition analysis. People might argue this is not accurate, it's not a good test, but let me tell you, the body composition analysis has got a sensitivity and a specificity of almost about 80%. In some machines, it ranges up to 85%. So this test is sensitive and specific by 85%, which to me is good enough. It's good enough assessment for the muscle mass. We all do serum total protein and albumin, but it's not very reliable, and the sensitivity, specificity of serum total protein and albumin is down to 60%. Imagine, so your body composition analysis has 80% accuracy for to assess your lean body mass, but the serum total protein and albumin, the blood test, has got only 60% reliability. So your BCA is much more reliable than your blood test. The best test to assess your lean body mass or your skeletal muscle mass is the plasma amino acids. If you send the plasma amino acids to the laboratory, they will tell you it's very expensive, it's a send out, it's not done locally. We sometimes have to send it to another country to get the test done, and it's not cost effective, it's very expensive, and it's not covered by insurance companies. So what do? I've got to rely on the best that I've got. I've got the body composition analysis with 80 to 85% accuracy is good enough for me. I will do serum total protein and serum albumin, but I know it's not very reliable. So why is albumin and total protein not reliable? Because several factors, many factors interfere with the synthesis of the albumin and the total protein in the body and the way it's released into the serum, like inflammatory cytokines or people who are put on reduced calorie diet, people on a diet. You know, all these things affect the concentration of amino acids and micronutrients in the serum. So serum albumin and total protein, we all do it in the bariatric surgery specialties. In every clinic, it's done before and after, and it's looked at in the follow-up process, but unfortunately, it's not very reliable. Someone comes to you with flu symptoms or with diarrhea or with whatever it is, you will see that serum total protein or albumin might be higher than what it's supposed to be or lower. It's just not reliable. I would not rely on this test to assess my patient's lean body mass. Besides, to see a drop in post-surgical albumin levels, let's say we have a patient who lost 60 kilos of weight in 1 year. You come and do their serum albumin, you will find it, in many patients, you will find it normal. So hypoalbuminemia is very rare finding to find after bariatric surgery. Usually it's within the normal range. But if you look at the BCA, the body composition analysis, you might see that they've lost 50% of their muscle mass, and yet albumin and total protein is normal. Let me give you an idea about the plasma amino acids, and I told you this is a very good test. It's probably the most reliable test, is to look at the amino acid levels in the plasma. So these are what we look at. We look at this is the list of amino acids we sent for. But as I said, it's expensive, it's not covered by insurance, and many patients would say, would not be interested in paying for this test. but it is there, it's available. It's a very good indicator. If you want to do a research project and if you want to look at your patients before and after and compare the muscle mass, I recommend that you consider the amino acid levels. So again, the reliability of the amino acid levels in the serum, you need to know when to do it. If you invest and do this test, which is very expensive and it's a send out, you need to know when to do it. The best time to do it is before surgery and compare it to 6 months after surgery or even 1 year. It's got to be more than 3 months after surgery. During the first 3 months of surgery, protein catabolism and breakdown of your muscles will increase the level of the amino acids in the serum, and that's not reliable. Although you're losing muscle, but the amino acid level in your serum is high. So it's not a good indicator. It's not accurate if you do it within 3 months of bariatric surgery. It's a very good test if you want to do a comparison immediately before surgery and 6 months after surgery. It gives you an idea of how much muscle mass or how much protein catabolism had occurred in this patient's body. So please be aware. I want to talk to you about this. Putting your patient on a diet before bariatric surgery is something that is now being controversial. We, as bariatric surgeons, have different thoughts about this. Some of us would not operate on a patient unless they've gone through a period of weight loss before the surgery. And many of us would refuse to do surgery on a patient who's gone on a diet before surgery. Let me tell you what we believe in our department and what we do. In our department, we follow the early recovery after surgery protocol. And with the ERAS protocol, you need your patient to be strong after bariatric surgery. You need them to mobilize, and you need them and you aim for return to an early return to normal lifestyle. Within few days after your surgery, you need a strong patient to operate on. We noticed in our department, if we put patients on a diet or we try to lose them weight, they get very tired after surgery. You'll be dealing with a very tired patient after surgery. So we're against the idea of putting patient on a diet or whatever liver reducing diet. We don't believe in it. We don't think it works. And we've been doing surgery for more than 12 years researched. Any surgery that we've done over the past 12 years has gone into an audit. We've looked at the statistics, and we're actually very closely watching our patients, and we're looking at the postoperative outcomes. And in our opinion, patients are not benefiting from the preoperative weight loss program. Actually, it's tiring them out, and they lose more muscle, they lose more lean body mass if you put them on a diet. So please be aware before you put your patient on a diet before the surgery. According to most of the literature, maximum acceptable fat-free muscle loss, which is fat-free mass loss, which is muscle loss, is 20% in 12 months. So you're allowed to lose your patient's skeletal muscle mass no more than 20% of the original mass. And that is, we look at before and after, and we depend on the BCA to look at the skeletal muscle mass. Another thing that is not evidence-based and it's not guidelined, we have no guidelines for how much protein to give our patients after surgery, but many of the literature would suggest volume of protein per day between 60 and 120 grams per day for most patients. Now, I really don't like to give a general number like that. I'm sure you know that it depends on your patient. How much weight are you going to lose them? What is their BMI? Are you dealing with a super morbid obese patient or a metabolic patient who's not very morbidly obese, but they've got metabolic syndrome? So you need to decide about your recommended protein intake case by case, rather than put a guideline and follow it and apply it on all patients. Pre-bariatric surgery proteins and essential amino acids. I don't know if Abbott is with us today to give us some overview about the protein supplements and the protein shakes. I wish they're with us today, but there is a lot available, and I will tell you what we do in our clinic. Now, we do know that there are no guidelines available for preoperative optimization with protein and amino acids. There is no guidelines for postoperative recommendation. So we're doing this just by observational studies. In our departmental audit, which we've done about this, patients who are optimized with oral or intravenous sessions of proteins and amino acids prior to surgery, they actually do better after surgery in terms of less loss of skeletal muscle mass. If any of you is interested in knowing our protocol and what we do, please feel free to communicate with us. We'll be happy to give you an overview of what we do. But we have a special optimization program for our patients, and we design the optimization program according to the case. It's not a protocol that is applied on all, it's case by case. We look at the BMI, we look at the metabolic status, we look at the skeletal muscle mass, spinal problems, we look at all this prior to the surgery, and we decide what optimization are we going to give our patients before we operate on them. Some good reading you will enjoy about proteins and amino acids and optimization. These are the references. I'm sure Kim will send you the copy of the slides, and you'll be able to retrieve these studies. I recommend this reading. You'll benefit a lot from reading, especially about the preoperative optimization. Now, what are your expectations and goals? Your expectations and goals post-bariatric surgery. Obviously, there are metabolic goals. We need to treat metabolic syndrome. We need to reduce the need for medications, hopefully stop the medications. There is a psycho-emotional goal. We need to give our patients the self-esteem, the social confidence, better performance. We need them to incorporate with their society more. So these people are happier in terms of the psycho-emotional status after they lose the weight. Now, cosmesis, we're not cosmetic surgeons, as you know. Bariatric surgery, we know what's going to happen with bariatric surgery. We know when people lose weight are going to flab and lose their hair and probably have brittle nails. So we know all that's going to happen, but we do need our cosmetic surgical colleagues to intervene and to assess our patients and tell us when is it that we're going to do the cosmetic surgery if indicated. But what we do, the follow-up post-operatively, we concentrate on the quality of skin. We continue with the protein intake, the amino acids, the vitamin supplementation. We continue to check for their minerals and trace elements and the levels, and we replace whatever is deficient. So we do look after them in this, and this is a goal that many patients would have, even so more important than their diabetes. They would like to look good and feel good, look good, and have a better health. In terms of the nutritional status, you know that regular follow-up postoperatively with the dietitian and with the internal medicine team is very, very important. What is the role, what's my role as a surgeon in the postoperative state, in the follow-up period? What is the role of the surgeon in the follow-up period? Almost near to nil. I refuse to work without a dietitian and without an internist who would follow up my patient after I operate on them. So the dietitian is the best person to follow up the patient and to look at the skeletal muscle mass, look at the fat loss, look at what we've done in terms of outcome and what did we achieve in the time frame that we have given. You do the planning pre-operatively and you follow it up post-operatively, but you not as a surgeon, but you as a dietitian and the internal medicine. So bariatric surgery is a multidisciplinary approach. We all sit together and we all discuss and put plans for our patients, and the follow-up later is by the dietitian and the internal physician. Now, the follow-up period is different, and there is no guidelines about the follow-up period, but because we're an academic center, we study our patients, we follow up our patients. So we actually see them 6 times in the first year, and 2 times in the second year, and yearly thereafter. So we see them 3 monthly in the first year, and then 6 monthly in the second year, yearly thereafter. Any deficiencies will be replaced by the internist. The protein and amino acid recommendation comes from our dietitian. Let me tell you about a case study. I just want to give you this example about this patient who was a 15-year-old when we saw him in the clinic. 15-year-old male. His height was 162 centimeters, weight of 131 kilograms, his BMI of 50, and he failed diet and exercise. He binges fast food. He eats a lot of sweets and drinks fizzy drinks. This is the quality of patients that we were dealing with. 15-year-old. I need you to look at the weight loss. Let's just go to the next slide. I want to show you the weight loss. Remember, before the surgery, he was a BMI of 50 and his weight was 131 kilogram. 1 year later, 1 year post-operative, his weight came down to 73 kilograms and BMI down to 28. So let me show you his blood profile. Look at this profile. His hemoglobin preoperatively was this much, 13.2, postoperatively was 15.3. Of course, this is considered as normal, so statistically, there is no significant difference. But look at, most importantly, the calcium. After losing more than 60 kilos of weight in 1 year, the calcium was 9.7 preoperatively and 9.9 1 year later. No deficiency at all. Look at the iron, 39 preoperatively, 80 1 year later. Look at the B12, within normal range before and within normal range after losing 60 kilos of weight. Now here is where this is important. Look at the protein and the albumin. So after losing 60 kilos of weight and preoperatively in a morbidly obese patient, they're the same. Total protein was 7.2 before the surgery and 7.1 after losing 60 kilos of weight. The albumin is even better after losing the 60 kilos of weight. But if you look at the skeletal mass index, the skeletal muscle mass, you will see that he reduced from 35 to 25, but this is still within the normal range. The normal range for this person's skeletal muscle mass ranges between 23 to 28. And as I told you, you're allowed to lose 20% of the lean body mass after bariatric surgery, and we did not lose that. He was 35 preoperatively and down to 25 1 year later. So this is still within normal range. And how did we achieve this? We achieved it by optimization, assessment, planning, optimization, as I taught you earlier. So what is the case study conclusion? The conclusion is the proteins and amino acid supplements, which we gave to our patient 3 months preoperatively, with the preemptive muscle strengthening physiotherapy, that has given him a transformation from a super morbid obese patient to just an overweight. So BMI dropped from 50 to 28 in 1 year, and you could see his parameters. He has no deficiencies, and not much lean muscle mass loss either, or lean body mass loss. The amino acids we give to our patients, this is just an example. It's very difficult to find these in our pharmacies, in the local pharmacies. My patients usually order these online, but this is the combination of amino acids we give to our patients before and after. I'm sure when Abbott speaks to us about the protein shakes and the protein supplements that they've got, we will talk about then the difference between taking an amino acid, which is a building block to this protein, and taking the protein. Probably taking the protein before the surgery is easier and it's doable, but after the surgery is difficult because of the bulk and the heavy feeling and not being able to drink enough. So amino acid tablets is a small tablet, it's got enough amino acids. It could be something that you'll have to consider for your patients. So in conclusion, bariatric surgery is life-changing if done for the right patient. So remember again, the right procedure for the right patient, right surgery for the right patient. You need to assess your patient and choose what's best for them. And regardless of what you choose, weight loss is usually associated with muscle loss, hair loss, skin loosening and flabbing. You need to think about the unwanted side effects like dumping syndrome, hypoglycemic events, diarrhea, staturia. It all depends. What procedure you choose, you have to look at the potential unwanted side effects and try to control them from the very beginning by choosing the right procedure for the right patient. Kim, I'm going to leave you to give us the questions, if you like, the test your knowledge questions, and I will take any questions that is there from the audience.
Thank you so much, Dr. Ines. I'll be posting the poll questions. Every attendees, you will be receiving a pop-up in your screen. You can vote on this screen and we will show the results afterward.
So Kim, are we waiting for answers and we're looking at the polls, or can I answer what the questions I'm getting?
I'll be ending the poll now and I'll be sharing the results.
Oh, okay. Bariatric surgery is an effective treatment for obesity because it helps you to change. The correct answer is the patient's mindset. Remember the weight regain that we suffer with bariatric surgery. Many of our procedures would end up with weight regain between 3 to 5 years after surgery. So you're not really changing the liver metabolism or pancreatic metabolism. You might be changing that temporarily until the body acclimatizes and gets used to it. But what you're mainly doing is you're working on your patient's mindset. So the correct answer to this is the mindset. And congratulations to a third of the audience, 31% answered it right. Right, well done, well done. Most of you answered it right. The total volume of the stomach after sleeve gastrectomy is approximately between 100 and 200 cc's. Let me just comment, please. The volume of the stomach is pointless if the gastric emptying is fast. Because the 100 or 200 cc of stomach volume, if you drink it as melted chocolate, it might contain 300 or 400 calories, and you could repeat that and do that repetitively all day, you're still not going to lose weight. So please remember, a sleeve gastrectomy or any restrictive procedure is only effective if the speed of gastric emptying is normal. If the speed of gastric emptying is very fast, your patient is not going to benefit from a restrictive procedure. Next question, please, Kim. So, Roux-en-Y gastric bypass, you're quite right. You bypass majority of the stomach and the duodenum. That's exactly what you're doing. Congratulations. Correct answer. Next question, please, Kim. The normal, someone is asking here, what is the normal speed of gastric emptying? The normal speed of gastric emptying is between 2 to 4 hours. When people eat, they should feel satiety for between 2 to 4 hours. That is the normal speed of gastric emptying. So when you have someone who empties in minutes, then that is an issue. Kim, I'm sorry, I didn't see the answer. Yeah. Well done to the majority who answered this right. So Roux-en-Y gastric bypass is fully reversible but technically challenging. However, in centers who are very experienced in the reversals, this is reversible. If I can very quickly comment, I think we've got a few minutes, very quickly comment on this. Reversal of bypass surgery is only done for very, very severe side effects, something like severe dumping syndrome, recurrent staturia or diarrhea. So reversal of bypass surgery is something that goes through assessment, optimization, exactly the same as when you're doing bariatric surgery. So well done to you. Next question, please. So amino acids, serum amino acid level within the first 3 months of surgery would increase, and that is falsely increases. It actually skeletal muscle catabolism and protein catabolism increases the level of amino acid levels within the first 3 months. And this is why I told you it's not accurate to do this test within the first 3 months of surgery. You would do it preoperatively before surgery, and you would do it 6 months later, and that gives you an accurate indication. Next question, please. Right, okay. So reduced calorie diet prior to surgery must be considered with care. Yes, someone in the questions asked whether we are following the liver shrinking diet. No, we don't, and we're very strongly against it. We've got observational study about this, and the outcome of the ERAS protocol that we do, which is the early or enhanced recovery after surgery, we found that liver shrinking diet tires out our patients, and the outcome is much better when you are not putting our patients on the liver shrinking diet. So the answer to this question here is correct. It must be considered with care, but in my department, I do not put my patients on liver shrinking diet. Next question, Kim, please. The sleeve gastrectomy was performed as a first component of the duodenal switch procedure. Yeah, well done. Many people think it was done as a first component of gastric bypass, but the gastric bypass procedure is a much easier surgery than the duodenal switch. So congratulations to the majority. Next slide, Kim, please. Uh, Let me just answer some of these questions. Gastric emptying time varies for liquids and solids. Yes, you're correct. It varies. The contrast we use is actually a very thick contrast, so it simulates something heavier than liquids, but lighter than the solid food. So this is why we give it a range of between 2 to 4 hours. So this is a correct answer, and this is not guideline. You have to consider your patient case by case, but most of the literature will tell you that the most appropriate protein you have to give to your patients is between 60 to 120 grams per day post-bariatric surgery, regardless of how much weight you lose them, regardless of the type of surgery. There are no guidelines about how much protein to give, but this is the recommendation. We have a question here. What about patients whom BMI is risky in terms of anesthesia? How would you deal with this type of patients? Well, if you get a patient who is super morbidly obese and they're high risk of anesthesia, you want to bring them to a lower risk for anesthesia. How much weight do you think you need to lose them preoperatively? Roughly 10% of their excess body weight, weight, 20% of the excess weight. Well, you need to have a guideline. If you come back and tell me, well, let's lose them 10% of their excess weight so that they're safer for the anesthesia. And someone who's super morbidly obese, this could mean 20 or 30 kilograms. Believe me, if an obese patient can lose 30 kilograms, would not come to you to clinic requesting bariatric surgery. It is very, very difficult. And as I told you, we've been observing our patients for the past 12 years. We're studying all this. Patients who are not fit for anesthesia, you put them on a diet, it doesn't work. In our opinion, in our observation, it doesn't work. So no, we don't put our patients on a diet. Yes, most of you answered this correct, or half of you answered this correct. Theoretically, the best answer is the last one, which is the plasma amino acids, the BCA, and the serum protein and albumin. But practically, as we discussed in the slides, it's not doable. So the best way to do it practically in your clinic is the body composition analysis, followed by the albumin, total protein, and lastly comes the amino acids, because you might not be able to do it anyway. That is the correct answer. Next question, please, Kim. I will take this opportunity to answer. Do you perform gastrography study postoperatively for your patients before you start clear liquids? Well, this question is purely surgical, and I will give a purely surgical answer. I'm not sure if it will help my dietitian and internist colleagues, but from a surgical point of view, if I trust my surgery, if I trust my staplers, if I trust the way I've done the surgery, if I have worked on a optimized patient with no deficiencies, then I would depend on the methylene blue test that I do during the surgery. When I finish my bypass or a sleeve, I would do methylene blue and look closely, look very carefully for leaks before I give them liquid diet. But doing a gastrographic meal the next day to find out whether there's a leak or not, in my opinion, it's something that is depends. Whatever the surgeon is comfortable with. I don't bother with it, to be quite honest, unless the patient is high risk for a leak, like a very poorly controlled diabetic or a patient who is hypertensive. So the best postoperative indicator. Now listen to this question. Read it clearly. It's regardless of whether you can do it or you can't do it. What's the best postoperative indicator for protein malnutrition? The answer is the very last one, which is the plasma amino acids, the BCA, and the serum albumin. However, again, that might not be feasible and that might not be practical. So the practical answer is the BCA, serum albumin, and the plasma amino acids in the serum. Next question, please, Kim. So do I perform a gastrography? Maybe in very few of my patients, but routinely, no, I don't. In fact, I let them drink water in recovery. The minute they open their eyes from anesthesia, we start walking, we do the incentive spirometry, and we drink 30 cc of water. This is what we do in our ERAS protocol, the Enhanced Recovery After Surgery protocol. Which is the best indicator or a better indicator for protein malnutrition after 3 months of surgery? Within 3 months of surgery, as you know, the serum amino acids will be high and it's not very accurate. It's because of the muscle and protein catabolism. So the best indicator within 3 months within 3 months would be the BCA, the serum albumin, and the plasma amino acids. But after the 3 months, the best indicator would be the plasma amino acids, BCA, and serum albumin and protein. So, however, what is most practical to your department, that you might not have accessibility to the amino acid levels, the testing. So you'll have to depend on the BCA and the serum albumin. So this is the correct answer. Next slide, please, Kim.
Thank you so much, Dr. Ines. That's all for our questions for today. Before we proceed with the question and answer from our delegates, we would like to once again welcome the presence of Abbott Laboratories SA. Though unlike last time, Abbott will not be having a presentation this time because one of the representatives is currently on leave. So we will be proceeding with the question and answer. Before that, Ms. Padua Alulayan would like to ask something. Ms. Padua, I will allow you to talk. Ms. Padua, you can unmute your mic if you have any further questions. All right, I think that's it. Moving on to the question and answer. One question here is about what if they are severely obese? Don't they have to lose weight before the surgery?
Well, again, as I said, it depends on the different surgeons have different opinions. In my opinion, personally, in my practice, no, I don't, because I believe if the patient can lose weight, would not come to me requesting surgery. A 200 kilogram patient is a high risk. 180 kilogram patient is still a high risk. If you have the proper setup, if you have the correct anesthesia requirements, if you have the correct instrumentation requirements to do your surgery, you would do the surgery on a 180 kilogram or a 200 kilogram patient. Losing him 20 kilos of weight, in my opinion and in my experience, it does not matter. So that is in my opinion.
Thank you, Dr. Ines. One question from Ms. Amina. How to deal with deficiencies since the absorption site is removed?
Excellent, excellent question. Thank you, Ms. Amina. Thank you very much. Now, here is when I say design your surgery according to your patient needs. If you're going to do a bypass, let me give you an example. For example, the mini gastric bypass. Now, for the mini gastric bypass, it's no standard. You don't put same measurements for every patient. You're going to have to go and assess the absorption of fat, sugar and carbohydrate. Where does it happen? And that's the bowel loop that you work on. And you don't touch the bowel loop, which absorbs the proteins, the minerals, the iron, the calcium, and what have you. So when you're doing a bypass procedure, and it is quite right, a malabsorptive procedure, please, you need to assess your patient and you need to decide your length. Now, this is a purely surgical thing, but an experienced surgeon in the bypasses would design the surgery according to the patient's needs. Now, let me tell you this. You know that as an average, we say that patients have 6 meters of small bowel loops, and that's how they absorb the food they eat, 6 meters. But this is very much genetic. People are different in their bowel loops, and we've got evidence that different genetics have different lengths of bowel loops. We've operated on patients from the African continent. They have much longer bowel loops than the Asians or the Indian subcontinent. African patients might have bowel lengths that reach up to 12 meters. And we are talking about an average of 6 meters. Patients from the Indian subcontinent have bowel loops that are as low as 4 meters. So if you put in a bypassed length of bowel loop, let's say for example 200 centimeter, and you apply that on all patients, now you will get patients who will benefit, you'll get patients who are not going to benefit, and you'll get patients who are going to be severely malnourished and with malabsorption. So you need to know the bowel loop length of your patient before you decide how much of it are you going to bypass. Usually we say we bypass 30% of the absorption in the bypass surgeries, and no matter what bypass you're doing, be it a gastric bypass Roux-en-Y or the mini gastric bypass or the biliopancreatic, whatever the procedure is, we look at an average of between 30 to 35% malabsorption. Now, my surgeon colleagues, what they do is they put a number and they bypass the same number on every patient that comes on their operating table. Now, you tell me, is that reasonable? If you have a patient with whose height is 2 meters, and you have this little patient with a height of 150 centimeters, is it logical to believe that the bowel length is the same in these two patients? So how can you put a standard number of a loop length to be bypassed and apply it on all? So that's a very good question. The answer to your question is, you're quite right. The only way to avoid malabsorption in people who are bypassed, like the example I showed you, the boy, the 15-year-old case that I showed you earlier in the slides, actually have lost 65 kilos in 1 year after a bypass procedure. And he had no deficiency at all. You could see his calcium, his iron, his B12, his folic acid, everything was within the normal range. Why? Because he had his surgery planned. The bowel loop length to be bypassed was planned. How small are you going to reduce the stomach size was actually planned. This is the answer to your question is, please plan your surgery. Don't have one measurement for all your patients. I hope that answers Ms. Amina's question.
Thank you, Dr. Ines. There is also a follow-up question from Ms. Amina. What kind of amino acid is recommended after surgery? Medium chain?
Yes, the amino acids that I recommend after surgery is the list I showed you in the previous slides. Let me see if I can go back to it and show you. But these are essential amino acids. These are the building blocks to proteins. There we go. I don't know if you can see this. These are the amino acids that we in our clinic. Can you see this?
Can you please share your screen, Dr. Ines?
Oh, okay. Let me go back and share my screen. Now, Kim, can you see me there?
Yes, perfect.
You can see the screen. These are the amino acids. If you go through the list, Kim will send you the slides later. You can get all these details. But this is what I give my patients, and these are given in tablet form. And you can give them in intravenous form as well. They come as peripheral TPN, but it's available in tablet form. It's a small tablet, very easily tolerable by the patients. And these are the amino acids that I recommend. Now, these are the building blocks to proteins, and patients tolerate them and can take enough of them, as compared to proteins or protein powder or protein shake, where people can't take enough of it because of the bulk. I hope that answers your question.
Thank you, Dr. Ines. A question from Dr. Berborta. Is many gastric bypass or ROX and Y gastric bypass is your preference?
Say that again, the question, please. I've lost the question, Paul, completely here from my side. I can't see questions. So can you tell me the question again?
Is mini gastric bypass or ROX-Y gastric bypass is your preference?
Again, a very, very good question. There is no perfect procedure and there is no worst procedure. You've got to assess your patient. I just showed you an example of a barium meal on a very fast gastric emptying, and I told you gastric sleeve is not going to benefit your patient. Similarly applies for the different bypasses, Roux-en-Y gastric bypass or the mini gastric bypass. All can be mild or severe or non-effective if done incorrectly on the inappropriate patient. Now, have you never seen a patient after a Roux-en-Y gastric bypass coming to you with weight regain? Have you never seen a patient who had a Roux-en-Y gastric bypass who had not lost weight or not benefit from the surgery? We see a lot of them. So again, what is my preferred procedure? Is a procedure that is suitable for my patient. Assess your patient right and choose the correct procedure. Now, again, your question is, I in a way understand what you're trying to ask, because you know full well that there are surgeons who can only do sleeve gastrectomy, so all their patients would be sleeved. Surgeons who can only do bypasses, so all their patients would be bypassed. What I suggest is to my colleague surgeons, please train yourself to do all types of procedures and choose the best, what suits your patient, and do that procedure. Don't be a sleeve surgeon or a balloon doctor or a gastroplasty guy or the bypass guy. Be a surgeon who can provide all. Now, one person might not be able to do everything, but you can have a department with surgeons of different interests. You might have a team for the bypass surgeries, you might have the team for the restrictive surgeries, but please, MDT, MDT, MDT. You need to sit with all your colleagues of the multidisciplinary team, discuss your cases regularly, and choose the right procedure for the right patient. I hope that answers your question.
Thank you, Dr. Ines. Another question, would taking protein supplements in post-operative phase provide all the nutritional requirements, DRI? If no, wouldn't this increase the risk of going into malnutrition?
Good question. And the answer is no. You can give all your patients proteins and they still can come to you with malnutrition. You're quite right. So again, it's what you do to your patient. If you do a severely malabsorptive surgery to your patient, surely they will come with malabsorption. But what I'm trying to say is plan your surgery right, assess your patient right, pick for them the correct measurements that would suit them. How long of a bowel loop are you going to bypass? How long of a bowel loop does the patient have naturally? And all this will determine how much malnutrition, malabsorption do you give your patient. So you're quite right. But post-operatively, when our internal physicians assess the patients, they would replace any deficiencies. And no, you cannot depend on supplements alone to randomly reduce the deficiencies. You need to follow up your patients. The acclimatization period is usually after 24 to 48 months, which means the first 2 years of surgery, still patients could lose too much weight, could be malabsorptive, could have malnutrition. It's only after the 3rd year is when they get into acclimatization, which means their body gets used to their surgery, and that's when they start gaining weight. I hope this answers your question.
Thank you, Dr. Ines. A question from Ms. Uma. Good evening, Dr. Ines. Do you have recommend during clear liquid diet the supplements?
Okay. First of all, again, this is very much dependent on the protocol you follow. In my practice, I don't put my patients on clear liquid diet for a long time. For me, it ranges between 3 to 7 days. So some people start eating after the 3rd day, and believe it or not, some people start taking soft food after the 7th day. Now, putting your patient on a clear liquid diet for more than that, you're having issues with patient taking in too much sugar, because the easiest thing for them to drink all day is the juices. And patients have this misconception of drinking natural juices. So they would be squeezing 20 or 30 oranges per day to take in their liquid diet. So I don't recommend liquid diet to go for more than 10 days. Assess your patient. If you're doing a low pressure system surgery like the bypasses, you can start feeding them the soft diet after the 3rd day. Eating normal diet, I'm not saying normal diet like steaks and grills, but at least I'm talking about yogurt, I'm talking about the soft diet. They can start taking that after the 3rd day, many of the bypass patients. So if you want to give your patient supplements during the clear liquid phase, if you had optimized them very well before the surgery, they would not need supplements within the clear liquid phase. This is why we recommend optimization prior to doing your surgery. If you had not optimized them well, you know you're tiring your patients out, because they'll be drinking soup and juice all day, and you don't know how much volume they can take in. So you could give intravenous supplements regularly, and again, there is no guideline, but you can get them. What we do is we bring them with every 7 kilos weight loss. Why every 7 kilos? Why not every 5 kilos? Why not every 8 kilos? This is observational. There is no guidelines, and I'm just telling you my practice. I bring in my patients to give them intravenous vitamins. Regardless of the deficiencies that is there, I give it to them after every 5 to 7 kilos weight loss. So the answer to your question, what supplements do I recommend during the clear liquid phase? You have the intravenous infusions, which is a very good option, or you have the liquid vitamins, which I honestly don't like, and I don't like to use it on my patients. I'd rather use the powder form, but the chewables, the chewies, that is all available. I don't prefer either of them. What I do is I optimize my patients very well before the surgery, and I bring them after every 5 to 7 kilos weight loss, and I give them infusion in my clinic. None of my patients leave hospital with vitamin supplements orally. Nobody goes home with a bag full of vitamins orally after the surgery. It's just my protocol. It's not necessarily with every other surgeon. I know many surgeons give their patients bagfuls of bags and bags and bags of vitamins to take home with them. The poor patient who's done a very tight sleeve gastrectomy is now expected to take a finger-length tablet of multivitamins. You know what, guys, it's just my own personal opinion. I do not believe with oral vitamins post-operatively, especially the first 6 months. I would just bring them in, give them everything intravenously, and optimize them very well pre-operatively. Next question, Kim.
Thank you, Dr. Ines. A question from Ms. Uhud. What is the normal speed of gastric emptying?
We've discussed this earlier. Normal speed of gastric emptying for water is different than for the thick liquids, is different than the soft diet, and is different than the solid food. So what we do is we give a range between 2 to 4 hours. So 2 hours for the liquids and 4 hours for the solids. That's what is the average normal according to the best of the literature.
Thank you, Dr. Ines. A question from Ms. Mira. What's the solution for the patient having his stomach above the diaphragm?
Ah, very good. Now she's thinking surgical. The patient who's having his stomach above the diaphragm, you've got to do a repair. You've got to bring the stomach down, which we call a hiatal hernia repair, because that is a hiatus hernia. That is a hernia through the hiatus or through the diaphragm. So we have to do that and then convert them to a bypass. I disagree with my colleagues who just go ahead and do a bypass procedure after a sleeve gastrectomy without assessing the hiatus, because with a sleeve gastrectomy, half of the stomach sitting up in the chest, acid reflux is a problem. When you convert that procedure to a bypass, then bile reflux becomes a problem. So something or another is going to reflux upwards. That needs to be repaired during the same session. You bring in your patient. When you're doing your bypass after a sleeve, you need to repair the hiatus hernia. Basically, what it involves is dissecting everything down back to the abdominal cavity and closing the hiatus, and then proceeding with the bypass procedure.
Thank you, Dr. Ines. A question from Ms. Padya. Why to give tablets of amino acids while we can give protein powder? Doctor, do you think that if lifestyle modification is not done pre-operation will lead to bad outcomes post-surgery?
I didn't get the second part of the question, but the first part of the question where she asks, why give tablets, not give proteins? Bring a patient of a sleeve gastrectomy patient who is full after one sip of water, and try to give them protein shakes or powder shakes and let me know how much of that volume they can take, when the literature is telling you you've got to give your patient between 60 and 120 grams per day. Good luck to you. If you can do that, it's good luck. But you can give that much amino acids through a small tablet that they can swallow. Even the amino acid powder is a less volume than the protein powder. So the answer to your question, why give amino acids, not proteins? No, you can give proteins, you can give amino acids, whatever is tolerable to your patient according to the procedure that you have done to them. Now, a patient with a restrictive procedure, believe me, it's very difficult to take protein shakes or even the powder. And a patient who had a gastric bypass would have a problem with diarrhea. Protein powder gives the bypass patients diarrhea or a very, very foul-smelling flatulence, foul-smelling diarrhea. People come and complain, doctor, I don't want to take proteins because it's very embarrassing. You see, these are, you need to ask your patients, you need to follow up your patients. I hope this answer helps you. What's the second part of the question, Kim?
Doctor, do you think that if lifestyle modifications is not done pre-operation, will lead to bad outcomes post-surgery?
Lifestyle modification is a very broad word, and unfortunately it is used non-scientifically. What you do to your patient is you counsel them. Number one, doctors need to listen. Before you put your patient on lifestyle modification, you need to teach your doctors to listen to their patients. Listen, take a proper history and listen to your patient. What is the cause of their overeating? Are they overeating sweets? Are they overeating junk? Is it just their stomach volume is very big? Gastric emptying is very fast? What is it that that causes their overeating? You need to first train your surgeons to listen to the patients. Every patient is different. Every patient has got a different story. I personally could spend up to 2 hours with each patient. Now, this is some of my, especially my hospital management, they would not like that. They would like me to see 1,000 patients per week rather than see 3 patients per day. So what I'm saying is, please, listen to your patients, train your surgeons to listen to your patients, and then you can counsel your patients and go on lifestyle modification. Now, in my clinic, I would never operate on a person who had not gone through diet and exercise and all these things. Patients who reach my clinic and reach to my office are patients who have tried everything and failed. So I would not see someone who had not tried everything else. Someone who comes to my clinic not trying anything and just requesting surgery, they don't even get assessed. I don't even offer them assessment. So someone who, when they reach my clinic, they would have done the lifestyle modification, they would have been followed up by the dietitian and the internal physician, and they come to me as a last resort. And when they come to me, I start my counseling sessions, education and counseling, education and counseling. I start educating the patient about their results. In fact, the clinic appointment, the name of the appointment is DOR, which means discussion of results. And when my nurses book the patients for this appointment, they block an hour and a half for each patient, an hour and a half consultation. What am I doing? I'm explaining to the patient their results. I'm explaining to them their metabolism. I'm explaining to them their biological clock. And I'm explaining to them what's suitable for their body. And then give them the option. Do you want a surgical intervention, or would you still consider trying non-surgical intervention? So you're quite right, but in another way, you need to open up your horizons a little bit. Lifestyle modification, that's a guideline. Everybody needs to go and try diet and exercise and pharmacotherapy before they come to have their surgery. But losing 20 kilos of weight in a patient who weighs 300 kilograms, and you think that's going to reduce their risk of anesthesia, I think that's not a very practical idea. The risk for anesthesia is risky at a weight of 200 or 160 or 150. The risk is assessed by the anesthetist. I honestly don't believe that weight is an issue. It's optimizing your patient to make them stronger for their surgery. Patient with a sleep apnea, put them on CPAP. Try to improve their sleep apnea before you operate on them, because that's a very high risk. But patient with a big liver, you've got the very advanced laparoscopic systems, you've got all these instruments, you can lift the liver. I'm not making it sound easy. It is actually technically very challenging in some patients, but I don't believe that a liver shrinking diet or lifestyle modification would bring your patient down in their risk on the operating table. I hope that answers your question.
Thank you so much, Dr. Ines. And once again, we thank you so much for your time for doing this lecture. I know you're a very busy person. We still have few question and answer, but we are running out of time now. We've just advised all the delegates to please send us a message so we can collect all the questions and we can share to Dr. Ines if you have any further clarifications. Once again, we would like to thank the participation, the presence of Abbott Laboratories SA, and for your time, Dr. Ines. We have very good comments received from our participants. It was a very excellent presentation, very reliable topic. We thank you so much. It was indeed really, once again, a wonderful topic with you, Dr. Ines. Do you have any further things to add?
Well, it's been such a pleasure, and I would like you, Kim, to give your candidates my email address. They're very welcome to ask questions. I'm very happy to share knowledge and to share our protocol. They're welcome to our department here to have a look. Maybe they even would like to attend surgery to see what we do and how we assess patients and how we decide what's best procedure for which patient. Everyone is welcome. I'm happy to share information and to answer questions. Kim, kindly provide my email address. Thank you.
Noted, Dr. Ines. And once again, thank you. Thank you so much. We will always be in touch with you. It is always our pleasure on behalf of THTUS to collaborate with you as always. Thank you so much, Dr. Ines. And to all attendees, once again, we would like to update you that at the end of this training, once we collect all the attendees' email address, we will be sending you an email with 2 links, a link of post-test and evaluation. And this is the process for you to get your CME certificate. Today, we have an accreditation from Department of Health Abu Dhabi for 1.5 hours. I'll be sharing yours, Dr. Ines, over email. You will be receiving your PDF copy of your certificate by the next coming days. Once again, attendees, have a safe evening, and thank you, Dr. Ines. I'll be in touch.
Thank you. Good night.
Stay
Thank
safe.
you.